So, good morning, everyone, and welcome to today's webinar. Today's webinar is brought to you by the Global Law Enforcement and Public Health Association, GLEPHA. We are a not-for-profit membership-based association, and we exist to connect leading experts, practitioners, researchers, policymakers to amplify proven good practice and promote integration across public health, law enforcement and community systems. We aim to have a positive influence on policy and practice, using evidence to support harm reduction and further upstream prevention across a range of issues. My name is Dr. Tracey Price-Allan. I'm Head of Social Research at Urban Foresight, where we work at the intersection of evidence, policy and practice to help people and systems think and act differently. I'm a member of GLEPHA's Board of Directors, and before moving into research, I spent some time as a social worker, working directly with people who were experiencing drug-related problems and multiple complex needs. I think that the people that I work with, their stories stayed with me and they continue to motivate everything that I do in this space. My PhD also examined the policy and legislative levers that Scotland could use to create pathways away from criminalisation and towards health and social care for people who use drugs. So this topic that we're going to talk about today is certainly very close to my heart. Today's webinar is proudly organised by our special interest group at GLEPHA on law enforcement and harm reduction, of which I serve on as board liaison. So this is the first of two webinars, and our aim is that this discussion will evolve and help to inform a pre-conference event on harm reduction at a workshop that will be taking place at LEF 2026 in Leeds this September. So today is very much the beginning of what we feel will be a longer conversation, and we absolutely value your engagement with it. Information on the pre-conference workshop will be shared in the chat, and you can see some on the screen now. So please do sign up, and if you're not already a GLEPHA member, then do consider becoming one. We would love to welcome you as part of our network. So today's webinar focuses on key learning from harm reduction in the Scottish context. Scotland has the highest reported rates of drug-related deaths in Europe. It's currently sitting at 19.1 per 100,000 people. But behind that number are the families, the communities, the people, and also the practitioners who've been living with this crisis, and in many cases pushing for change despite significant systemic and legal constraints. What's remarkable about the Scottish story is that it has produced some genuinely bold responses. A national Naloxone rollout to frontline police officers, and the opening of the Thistle, which is Scotland's first safer drug consumption facilities. Now, these are not small things. They represent hard-won shifts in how people and how a system think about their role and responsibilities towards the people they're serving. It's been the work of many. Today, we're going to hear from three people who've been instrumental in helping to make those shifts happen. So a few quick housekeeping things before we begin. As I've said before, do use the chat, introduce yourself, tell us your name, where you're based and what you do. We do love knowing who's in the room, and it helps us to make sure that what we say is appropriate to the audience that are there and is going to be interesting to you. If questions come to you during the presentations, do drop them into the chat too. We're going to be monitoring that throughout, and we'll bring your questions into the panel discussion after all three speakers have presented. So we've got a short amount of time together and we've got loads of ground to cover, so let's make that time count. First up, we've got Gary Ritchie. Gary is a managing partner within the Global Consortium Group. He's a former Assistant Chief Constable within Police Scotland. He's led the development of Police Scotland's first drug strategy and spearheaded a shift in focus from enforcement to harm reduction. He also oversaw the national rollout of Naloxone to frontline officers. Gary's a strong advocate for public health approaches to policing. He's collaborated internationally on leadership and harm reduction initiatives, and he's chair of the Scottish Institute for Policing Research's International Board. Gary's talk title today is The Impact and Ripple Effects of Police Scotland's national rollout of Naloxone and associated officer training programme. And he'll also touch on harm reduction and cultural shifts more broadly. I'm going to pass you over now to Gary.
Thanks very much, Tracey. Let me just share my presentation and we'll get started. And I should say, folks, first of all, thanks very much for attending. It's a pleasure to speak to you again on something that's really close to my heart. The three speakers today, this is more a kind of joined up presentation, so we have coordinated. So a lot of my presentations about setting the groundwork, certainly from the police rollout to Naloxone, and then Inga will come in and talk more about the actual results and the academic influence behind that in a broader sense. And then Kirsten will speak more about some of the detail around about the drug consumption facility, etc. So, and I'm going to be battering through this, but we will share these slides at the end if you're interested. So don't worry if I rush through it. So I often start by saying that Police Scotland is a different kind of police service, and that is because of our the basic mission and the legislation on which Police Scotland was founded back in 2013. The Police and Fire Reform Act actually says that Police Scotland is responsible for protecting the safety and the well-being of people and communities. And as far as I know, and I've said this speech in quite a few international arenas and nobody's actually corrected me, I think Police Scotland is the only police service in the world that has well-being having equal prominence in the mission as traditional elements of policing around safety. And how did that actually, and that moves policing into the public health space, but how did that actually translate into policing? Well, first of all, it comes down to attitude. You're moving beyond typical enforcement and you're looking at vulnerability and looking at harm reduction as a service. You're looking at that from a partnership viewpoint. You understand Police Scotland taking a public health approach. They can't achieve anything if they don't have partnerships. It's not a typical space for policing to work in. Therefore, you need partnerships with health agencies, with a health service, with support groups, with Public Health Scotland, etc. It's about focusing on the root causes, or the causes of the causes, to use nice public health language, rather than typical policing prevention, usually in that third tier where the problems are arisen, it can't be reduced, so you just try and use the harm. It's about pushing upstream and the prevention strategies, looking at where policing can operate in those areas such as poor mental health, poor education, poor environment, worklessness, inequalities, childhood trauma, not necessarily typical areas where policing would operate. And the question becomes not whether we should operate there, but how we can actually operate there to help reduce demand, which is policing demand as well. And then, as I'll touch on as we go through the presentation, the cultural change is actually required. So that's the philosophy that comes from the change in the legislation, first of all. And how that then translates into structural change. Well, what Police Scotland did was they created a new directorate called Partnerships, Prevention, Community Wellbeing, staffed it with 300 dedicated police officers and staff, purely focused on developing the partnerships and developing the strategy to address that well-being element of the policing mission. They created a new ACC role that was again dedicated to that, and that was a position that I took up in 2017. And we entered into new formal agreements. As I mentioned there, we had information sharing agreements with many health and social care agencies across the country. But we also entered into big national arrangements. One of the strengths of Scotland is that national policy framework. So actually trying to leverage the benefits that come from that by entering into formal agreements with bodies such as Public Health Scotland. But as we say, we have a drugs death crisis. And how did then the change in the legislation affect Police Scotland's approach to policy, particularly in light of the horrendous situation that we've been dealing with for the past few years? Well, there wasn't actually a drug strategy in Police Scotland. The approach to how we dealt with drugs was wrapped up in a broader serious and organised crime strategies, and therefore was focused on enforcement and intelligence and disruption. And there wasn't any focus really from a strategic perspective on vulnerability and harm. So when I took over, I immediately changed that, and we created a first ever bespoke Police Scotland drug strategy that was focused on harm reduction. And that changed enforcement immediately, because the focus moved away from traditional brown powders, white powders, etc., and more into the drugs that we could see were causing harm, which was synthetics and benzos, etc., street Valium. But sorry, I've put up the wrong presentation. There should be a slide in here about the creation of the Drugs Death Task Force. So I'll just talk through that very briefly. When the Drugs Death Task Force was set up, that brought together the number of health agencies, social care agencies, support agencies. I also brought together the frontline operators, including policing and ambulance, and also very prominently lived experience in those who have perspectives from the harm that drug caused. And this was the Scottish government mandated response to actually dealing with the drugs death crisis. And one of the things that policing was asked to do was to examine its policy, which was not a policy, but certainly a decision to not have police officers carrying naloxone, and actually challenge ourselves to revisit that and look at the reasons why we wouldn't carry naloxone as police officers, considering the fact that the reach and the proximity to communities, particularly vulnerable communities, constantly, 24 hours a day, 365 days a year that policing has, would seemingly put them in a perfect position as first responders to people who are in crisis, to have naloxone on their belts if there was a suspected drug overdose there. That was what we were asked to examine. And I took that to an executive that was divided at the time, because
This meeting is being recorded.
The attitudes were that, no, that's not really a job for policing. It's a bit more mission creep. This is a health issue. And that was, again, from about half of my executive colleagues at the time. But I managed to get us to agree that we would embark on a test of change. And that test of change involved us, first of all, setting up a policy, which was really important to me. And I think that's something we'll come back to in the discussion. We have a policy that actually moved from policing not carrying naloxone to one which said we are at least going to look at the benefits of police officers carrying naloxone. So it raised the possibility of it being a real thing. We identified 3 areas that turned to 5 through the test of change, and we trained all the police officers in that area. But we didn't just train them on how to use naloxone. We used the opportunity to give them details on the extent of the drugs crisis and the drugs death crisis. We used our partners, and Kirsten, who'll speak to you later, was an absolutely critical member there and speaking about the lived experience and the benefits that could come from that. And then, because of some of the challenges that we faced, particularly from the staff associations, we allowed our officers to volunteer at the end of that training as to whether or not they would want to carry naloxone through that test of change. And I'm happy to say, although those who were advocating against carrying naloxone considered that police officers did not want to carry naloxone, and that was why they were representing them, 80% of the officers who were trained agreed to carry and use naloxone for the 6-month period that we were carrying out the test of change. And we then deployed that to them in the 3 areas across the country. We would never have done that without the level of collaboration that we'd established through the Drugs Death Task Force. There's that slide there. I've just put it in the wrong place, so I'll sort that before you get it. Apologies for that. That's what happens when you do things at the last minute. So as I said there, the training covered understanding opioid overdose, how to use intranasal naloxone. There was concerns that police officers would be carrying syringes. But looking at the police response in respect of harm reduction and what our responsibilities are there, policing has a responsibility to protect life. This was a first aid response that would stop people dying until an ambulance was able to get there. So it spoke very, very much to the well-being element of the mission, but I also think to the safety element of the mission. And that those who were more traditional seem to forget, in their attitudes in opposing this, seem to forget that protecting life was a fundamental part of the policing mission and philosophy. I'm just going to breeze through this because it was one of the most important elements, that there had to be an independent evaluation to help us build the evidence base to allow the service to make the right decision, whether it was to carry naloxone or not carry naloxone. And at the time, I felt that was going to be an influential decision for policing more widely than Scotland, because a lot of the same arguments were being heard across other countries in the UK and beyond. So I'm not going to spend much time on this because Inga's going to come on and speak about the evaluation in detail. And she's going to tell you the results of the test of change and how that was framed. But suffice to say, as you know, it became, following that test of change, it became policy for police officers in Scotland to carry and use naloxone across the country. We became the first force in the world, and I still think the only service in the world that equips every single frontline officer with naloxone. And the policy is that they should carry that in their belt and use it if there's ever any suggestion that they come across somebody who is suffering the effects of overdose. So when you talk about the ripple effect, I think it positioned policing in Scotland and was a very public demonstration of that change in attitude, our willingness to actually go beyond the traditional perspectives and what policing should be in terms of, you're just catching criminals and tackling crime. But it positioned us differently, and it was very important to do that. And that led to that willingness and that default position changing from "that's not our job" to "how can we help?" And Kirsten will speak about the drug consumption facility in Glasgow, because of what we did with naloxone, because of the attitudes that developed, our position was how could we help, rather than we can't do anything because the legislation is the legislation, and if police officers suspect somebody's using drugs, then they're duty bound to actually intervene. Otherwise, they may be neglecting their duty. So we found ways to navigate that and create policy. As limited as it was still a policy that demonstrated that policing was supporting an initiative that was going to help save lives of vulnerable people. I think that there was really deepened partnerships that came from that particular test of change and the decision to pivot into a more health-oriented approach in policing. And that was a springboard for partnerships to help policing look at different ways in which it could actually address vulnerability in society. However, it's not all good news. I think the naloxone rollout hasn't yet created a change in legislation when it comes to misusing drugs. I thought it would have more influence because of the success of it and showing how a change in legislation could actually help vulnerable people and reduce deaths. That's not happened. I'm disappointed that more services across the UK, who I know I've been looking at, I know there's some people in the call because I've seen the names coming up, and I know that they've been involved in strong advocates for police officers carrying naloxone across the country. And yet it seems that it's not happened to the same extent. There's definitely been movement. There's definitely been development and an increase in police officers carrying naloxone across the UK. But those old arguments persist. And it was fairly recently that I was on a call where, again, those old arguments have all been addressed by the developments in Scotland and all been addressed by the test of change and the evaluation. To I think, which should be the satisfaction of any objective observer, they still persist. The lessons that Police Scotland learn, I don't think, have been adopted to the extent I would have hoped in other places. And now we see a reversion again, and this happens. It happens throughout history. Whenever we deal with crises, particularly in funding for policing and other public services, there's a retrenchment. There's a step back to, well, we can't really afford this type of partnership working. We can't really afford to be innovative in other spaces because we've got to go and just catch criminals because that's what the public want. Instead of learning the lessons of history, stepping into partnerships at a time of crisis, because the people who are suffering here are the most vulnerable in our society. Step into the partnership arrangements, step into more innovative places to actually address the vulnerability, and because that prevents demand for policing and that helps us achieve a good standard of service delivery, even with reduced finances and a crisis in funding. Just continuing to do what we've done for the last 100 years in policing and enforce and arrest and focus on crime only leads to the situation that we're dealing with just now, and the levels of demand that we deal with just now. Just demand means trying something different, but that doesn't happen. So I would say that that's still there. And finally then, as I've said, You know, this is a model that's worth replicating for so many reasons. It's culturally based, and it's challenging traditional cultural attitudes in policing, and therefore, as a result, policing modernises to an extent. If we don't, we just keep making, as I say, the mistakes of the past and expecting different results. Using an initiative like Naloxone as a springboard, I think immediately positions the police service in a different attitude in respect of dealing with vulnerability. And as we've proven, harm reduction saves lives. There's no doubt about that. The evidence, Naloxone, not to start eating into what Inga's going to say, naloxone's been used over 1,000 times in Scotland. That's 1,000 interventions that police officers have made that they wouldn't have. Might not be 1,000 lives saved. It might be no lives saved, or it might be over 1,000 lives saved. It doesn't matter. It's the fact that policing were willing to do that. Policing were willing to take that stand. And the leadership in policing in Scotland was committed to that change at the time. It is a model worth replicating because of the degree of change that it signals to the public about what the potential of policing is in respect to helping people who are vulnerable. And that's me. Thanks very much.
Thank you, Gary. What an insightful presentation you've given, and we very much appreciate it. And as you say, this is going to just flow nicely into Inga's presentation. She'll pick up on some of those things. What I'm struck by is how much it's a combination of evidence and people who won't give up pushing that evidence forward. And I think that's so important. I'm sure we'll pick up on that as we go. So next up, as I say, we've got Inga Heyman. Inga is Associate Professor of Policing and Public Health at Edinburgh Napier University in Scotland. Inga's international, interdisciplinary, clinical, educational and research career spans over 42 years. I won't say over, Inga. Her professional practice focus lies at the intersection of policing and public health, and is underpinned by her clinical practice as a dual-registered adult and mental health nurse, working across health and police services in Scotland and also Australia. She is an honorary member of the Faculty of Public Health. She's also a fellow of the Global Law Enforcement Public Health Association. She's a fellow of the Higher Education Academy and honorary forensic nurse consultants. Inga's title today, as you'll see, is the evaluation of the carriage of naloxone by police officers in Scotland, and she's going to talk about the impact beyond saving lives. I'll give you the floor, Inga. Thank you.
Thank you so much, Tracey. That's a lovely introduction, and it's lovely to see so many familiar friends and colleagues from across the globe in the presentation today. So thank you. My presentation today, Vi is going to be moving through my slides, so apologies in advance for me saying, Vi, can you move on to the next one? But Vi, could you do this? Could you please move on to the next one? Because my title's already up there. Thank you. I'm going to spend a little bit of time. Oh, can we go back one? Thank you. Just go back one. Just speaking a little bit. Can you just go back one, Vi? That's it. Perfectly. Thank you. Speaking about the evaluation, the carriage naloxone by police officers in Scotland, it was headed up by Dr. Peter Hillen, who did a fantastic job of bringing a team of researchers together to really evaluate the work that Gary was talking about earlier around the police carriage naloxone. And it was conducted by Edinburgh Napier University. And the report, I've got the link to the report at the end of this presentation, and that's held on the wonderful Scottish Institute of Police and Research site. If you just flip forward, thank you, Vi. So you can't get to a Scottish presentation with a lovely picture without a lovely picture of Edinburgh Castle. Other tourist areas are available, but I think this image really sort of makes me think a little bit about how positioned this is for police in Scotland. Just a little bit about the international background. Naloxone is an emergency antidote, as you know, to opiate-related overdose, and it's been a key part of emergency responses for many a year to prevent drug-related deaths. And Scotland is definitely not the very first people for police officers to be using it First responders, police officers have been using them in North America for a while. So in 2010, police officers in Massachusetts were the first law enforcement officers to trial the carriage and administration of naloxone in the USA. Again, in Canada, it's been piloted, it's been used and piloted in the West Midlands in England. But spoiler alert, Scotland was the only and the first country to equip every serving officer with the training and the kit to carry naloxone. And there's good reason for that, as Gary's already highlighted. Scotland is one of the highest drug-related death rates in the developed world. In 2021, at the time of the pilot or the evaluation that I'm going to discuss, there were 1,330 drug-related deaths. So there is a really good reason why we had to change, and I hope Gary's sort of laid out the leadership behind that. We continue to have the highest rate of drug-related deaths in Europe. Next slide, Vi. When the pilot was first proposed, there was quite a lot of opposition to the pilot from the Scottish Police Federation. The pilot was a test of change. It developed in 2021, and the opposition for the test of change was really very public. And Gary might be able to speak about that a little bit further down the line. Naloxone was discussed as a sticking plaster in relation to the drug crisis. There was real fears around increased workload and mission creep. So is it a medical matter pushing into policing? And also there was a lot of discussion around the safety of naloxone and the legal repercussions. So clearly that had to be considered during the training of officers to carry naloxone. And actually, you know, we were really keen to continue to hear about that during the evaluation to see if the training made a difference. Next slide, Vi. So the pilot took place in 3 key areas between March and October 2021 in Falkirk, Glasgow, Dundee. Actually, there was more than that. There was Stirling and Caithness. And interestingly, and we might come back to this, the training in the pilot areas was compulsory, but the carriage was voluntary. There's an important question around or discussion around that, I think, towards the end of this. 888 officers were trained. That represented 87% of the workforce. And during the training, there were some officers expressed strong opposition to the initiative throughout. Again, frequently that was coming from the Federation. But the uptake of naloxone packs by police officers at the end of the training was 81%, which was really high. We believed was really high, considering it was voluntary to take the kits. Some of the kits were subsequently returned, but we can come back to that. So during the pilot, there were 51 incidents where naloxone was administered by police officers and where there was a suspected overdose. Next slide, Vi. So the evaluation. What did we see? The project was, or what did we do? It was a mixed methods process of evaluation. We were assessing the knowledge, the attitudes and the experience of the police officers and the effectiveness of their naloxone training. We also did interviews with community stakeholders to try and get an understanding of the broader rollout and what did our community stakeholders think of police officers carrying naloxone. A total of 356 police officers completed the questionnaire, with 41 people taking part in the interviews in the focus group. We also had the interviews were carried out with people who used drugs and their family members, support workers and key strategic stakeholders. Thank you, Vi. So I'm not going to spend ages speaking about the actual nitty-gritty of what we found. Like I said, if you need that, it's in the report, which you can get the link to at the end of this presentation. But there were barriers that we found during the evaluation, and these have subsequently been addressed within the training. But there was a belief that police officers were under pressure to deal with a huge range of vulnerabilities, and the substance use was just another one. So, you know, issues around mental health related responses, that this was just something else for police officers to do. And this perception of poor partnership working, particularly with ambulance services. So there was a real concern that police officers would administer naloxone, but nobody would be coming to support them, that they were going to be fully taken over this medicalised side of work with perceived delays and poor communication. So one of the strongest feelings that we heard in the focus groups in particular was a lack of consistent follow-up support. So any different referral pathways across the areas. So this is a quote from one of our officers. It's like fighting a fire because we're administering naloxone, but the services aren't coming in behind us to backfill that. So these were kind of some of the barriers that the future work, and Gary might be able to speak about that, but how that influenced that is going forward. Thank you. Bye. However, there were many, many facilitators, and you know, by far the majority of officers that we interviewed said that the training was reassuring. It convinced them to carry naloxone. So the high uptake of naloxone kits, as I said, there was 80%, 81%. The community participants were overwhelmingly supportive of the pilot, and they saw absolutely no reason why it shouldn't be made compulsory for police officers to carry naloxone. And it was really clear that naloxone provided a really effective first aid tool, which really allowed the police officers to carry their duty, as Gary had said earlier on, about communities and well-being, but to preserve life. All the participants agreed that intranasal naloxone really increased their ease of use and therefore their acceptability. That we could see that police officers are often first responders to the overdose, and they were absolutely in the best position to reverse that overdose. Many of the police officers were really clear and compassionate, and I'm going to come on to this slide next, that they really clearly cared about their communities that they worked in, and they desperately wanted to make a positive impact of the lives of people that were using drugs. That came through incredibly strongly in our on our interviews and our focus groups. One of the things that were some concerns from our community participant stakeholders, that they were really concerned that police officers would be at risk of an aggressive response if naloxone was administered. But the police officers were really clear that that would not deter them from administering naloxone. So there were some very strong comments and very strong findings about facilitators for the naloxone rollout. Next slide, Vi. One of the things that really hit me, particularly is in doing the focus groups, and we spent a lot of time listening to officers, is the compassion that came through, the compassion that they felt better equipped as officers. And I put a couple of three comments in there, but the one that really, really, really hit me most is the final comment there. And I'll translate it out of a Scottish language. It says, it is much easier for me to scoosh something up someone's nose, so to use naloxone, than it is to go and knock on a mother's door and tell them their son has died. So this feelings of compassion and feeling better equipped was very, very strong across the findings. And one of the things that another one says, I can't stop people from taking them, but I've saved a life right there and then. So that came through very, very strongly. Next slide, Vi. So the impact, as we know, as Chief Constable, mandated all officers to be trained. Naloxone is proven to be really safe and effective as a first aid. There were concerns about the liability, but that's been included and was actually included in the initial training. So particularly provided by PERC, the Police Investigations and Review Commissioner, and the Crown Office. So that's really been followed up by our excellent trainers within the naloxone for police officers. Really strong development partnership working between ambulances and follow-up initiatives. Just to date, the administration from yesterday is 1,148 times it's been used by Police Scotland. Next slide. Right, so beyond saving lives, the visible carriage in naloxone has really strengthened relationships with communities, particularly among people who use drugs. So now often police officers are being, so what we hear is police officers are being seen as a source of help rather than enforcement. The Scottish evaluation, probably not to the level we want to, but it has been used to support some of the roll out in England and Wales. One of the things I find is quite interesting is we've just completed a evaluation of the consensus statements between emergency services in England and Wales. In the naloxone, the carriage of naloxone is cited as one of the key approaches, preventative approaches around that. And there's been many lessons learned about from developing and embedding the police and public health prevention approach. And we can speak about that in a little bit further on. But potentially thinking about how training is developed and whether things are mandatory or not to carry naloxone. Last one, just a takeaway message, is that Gary had spoken about that earlier, this independent evaluation, and I'm not just saying that as a researcher, it was an incredibly important lever for change. So when we're thinking about building this, continuing to build the momentum around harm reduction, we need to ensure that innovative practice is, for any innovative practice, that the evaluation is absolutely embedded in it. It was one of the key levers. Often that's forgotten in many policing evaluations. It's kind of an afterthought. The lessons around naloxone can be mirrored around other initiatives. I'm really privileged today to be presenting between two people who I believe have got incredible moral courage. It's really fundamental for both police and healthcare and for our political leaders to have moral courage here. We can't just stop at this point, and we need to build on this trajectory of change. The challenges around that for me is that those relationships to build and to show moral courage around change are fragile. People leave organisations. We need to continue to build that. And we also really, really need to think about innovative funding structures within this change as a political whim that are happening at the moment. So I will finish now because I know I'm short on time, but we're very happy to explore some of those messages at the end. Thank you.
Thank you, Inga. Thanks for another impactful and insightful discussion. I think I can see the threads that are weaving through both, and I'm sure that Kirsten will pick up more as well. We're going to move straight on to our third speaker today before we move into the discussion. So next we have Kirsten Horsburgh. Kirsten is CEO of the Scottish Drugs Forum. She's played a pivotal role in the coordination and development of Scotland's national naloxone programme. She's a passionate advocate for safer drug consumption facilities, but for harm reduction and compassion more broadly. Kirsten is on the oversight board of Scotland's first safer drug consumption facility, the Thistle, that's been mentioned a few times, and is trustee of Harm Reduction International. Her title today is Introducing Safer Drug Consumption Facilities in Scotland. I'm going to turn the floor over to you now, Kirsten.
Sorry, I was just having a technical moment. I'll be back in a second.
Pleasure.
Okay, thank you very much for the introduction. And thanks very much for inviting me to come and speak today. It's great to be among friends and having this important conversation. So my talk today is going to be about where we're at now, what progress has been made and why more is needed. And there is a key message on this talk, which is very simple, and that is that we've made an important start, but we are far from where we need to be. SDF is a national organisation focused on reducing drug-related harm, and this issue sits at the core of everything that we do. And as well as being on the oversight board of the Thistle, my previous involvement around this discussion has been as a member of the National Forum on Drug-Related Deaths some time ago, and I also did a travel fellowship in 2015 to try and bring back some of that learning to Scotland. Scotland continues to have the highest reported rates of drug-related deaths in Europe. There is a real human impact to all of this. So since 1996, when recording of these deaths began, we've lost almost 20,000 people to accidental and preventable overdose deaths. People often forget that the driver for the Glasgow facility was the HIV outbreak, not in fact drug-related deaths. And it's an important distinction as we look forward into what we need to do differently in the future. Alongside this time, I also did my travel fellowship, and at the same time, there was a needs assessment taking place in Glasgow, Taking Away the Chaos, which was published in 2016, which was looking at the particular needs of people who are injecting drugs in public places in Glasgow city centre. And that specifically looked at the unsafe outdoor environments that people were using in, and it confirmed what we already knew, that there was a clear need for a safer consumption facility in Glasgow. It wasn't a new idea, it was an evidence-based response to a real and urgent problem. And certainly these facilities had existed all over the world since the 1980s. And this recommendation for a consumption facility in Glasgow came as a number of interventions that were recommended, including heroin-assisted treatment and other improvements to service provision. So what we know is that people are already injecting in unsafe environments, in alleyways, stairways, and stairwells, and unsafe places. The picture on the left there was actually a lane that was directly outside the window of my office in Glasgow. So sadly, we could look down into the lane and see the spaces that people were using to inject, and as an organisation who were desperately trying to make the case for an injecting facility, having to run down to the lane to check that people were alive or in need of help was truly frustrating in terms of the need that was right there in front of our eyes. The picture on the right was in another area that I was looking at just ahead of going on my travel fellowship. So as you can see, people in really sort of unsafe, undignified conditions, and how we expect people to not have low self-esteem when this is the situation that they're faced with is beyond me. So the issue isn't whether drug use happens, it's where and how safely. Responses in Scotland have been slow and somewhat constrained by the Misuse of Drugs Act. As people will know, we have a Lord Advocate in Scotland who's the Chief Legal Officer and is able to make statements of prosecution policy to enable things to happen. So back in the day, there would be a statement of such kind to allow the legal operation of needle exchanges. We saw changes to naloxone during COVID that the Lord Advocate facilitated for us. So for us, there was a clear pathway for us to be able to circumvent really the Misuse of Drugs Act and be able to push for the Lord Advocate to put this in place. However, when this was first proposed to the Lord Advocate almost a decade ago, It was declined, and the reason being that the Lord Advocate felt that it wasn't within their gift to do so, and it was pushed back to the UK government to make some change to the Misuse of Drugs Act. That was hugely frustrating, and we continued to make the case that we did feel it was within the Lord Advocate's remit. A new Lord Advocate was in place several years later, and in September 2023 made the statement that it would not be in the public interest to prosecute people who are in possession of substances in such a facility as a safer consumption facility. So that opened the doors for the facility to be introduced in Glasgow. But as you can see, it leaves the legal situation in quite a precarious position based on the opinion of whoever is in that post. We're in an election year in Scotland at the moment. So on May the 7th is election day here. Another Lord Advocate will be appointed. We don't know if it will be the same person, but history would tell us Lord Advocates are normally in post for 5 years. So I am very hopeful that we don't see any backward steps following the election. And all of this has been a major reason of why things have been so slow. Finally, in January 2025, the Thistle opened its doors, representing a significant step forward. The service is a compassionate approach to drug use that provides a supportive space for people to use drugs more safely. There is the provision of sterile equipment, fast response to overdoses, and connections to wider support. It meets people unconditionally where they're at. Because of time today, I don't have time to talk about all the fantastic work that they're doing in the Thistle, but please take a second to scan the QR code there, and you'll see a great video from our colleague Lynn MacDonald, who was in the chat earlier, talking about exactly what this facility does. In its first year, so its anniversary was in January of this year, it's already shown real impact. You can see there the number of individuals who've registered to use the facility, how many injecting episodes have taken place, and additional interventions that have been provided. In addition to that, the staff in the facility have responded to almost 100 medical emergencies, and thousands of referrals to additional support such as treatment, housing, etc. have been made. And we always talk about people being hard to reach, but the reality is that our services are often very hard to engage with, and this service demonstrates thoroughly what it can mean for people when you provide that compassionate, trauma-informed service. And it reflects what we see internationally, that these facilities save lives and they build trust. But consumption facilities don't exist in isolation. The issue is way bigger than one facility. So consumption facilities are part of a wider harm reduction approach. We also need to explore the different models that we could be introducing in Scotland. And this is not about one solution. It's about building a system with the right services at the right time for people. And that includes wider harm reduction picture, such as drug check-in facilities, better access and provision of treatment services, and a whole range of supports that should be provided. And it also means that we need to be looking more upstream in terms of prevention and addressing the real drivers of drug-related harms like poverty and deprivation. Otherwise, we're always going to be firefighting. And of course, we need policies and positions that transcend parliamentary cycles and are not at the mercy of that every few years. So one facility in Glasgow is not meeting the needs of the country. If we're serious about reducing deaths and harms, scaling up these services are essential. Our manifesto calls for a range of policy and practice improvements, and that also includes the decriminalisation of people who use drugs. And there's a link to our manifesto there for you to look at. If you want to continue the conversation on that with us, we'll be doing that at our conference in August. It's a real opportunity to bring together policy practice and, crucially, lived and living experience. And I guess just to finish, that safer consumption facilities are not a radical idea. They are a practical, compassionate, evidence-based response to a crisis. They honour human dignity and human rights. And whilst we're also having a focus on naloxone, I guess what I would also say is that naloxone stops deaths, but our policy will stop overdoses. And I will stop there so that we have some time for conversation. I'm very keen to do that. Thank you very much.
Thank you so much, Kirsten. And thanks to all of our speakers. We're going to move now into our discussion. So I'm going to start by posing a couple of questions to individual members of our panel, but the rest of the panel do feel free to jump in and respond. I've also been capturing, there's a couple of comments and questions in the chat, so we'll get to those too. We are due to finish, we're actually here until just after 11 o'clock today, so we're going to try and keep it to 1:15 at the very latest, because we recognise that people have got other things to get into, but it's such an important discussion. So across the presentations that we've heard, there seems to be a running thread around all of them, which is the idea that policies and practice, even institutions and, well, maybe not institutions, but interventions can change. But often it's a change at a cultural level and then at an individual level that influences how change happens on the ground. So Gary, I'm going to come to you first. From your perspective of being on the inside of Police Scotland when some of those changes happened, what was the resistance like? Can you talk us through that, and how did you overcome some of the resistance that you faced?
Well, I think we start with, as I said before, the traditional culture in policing, and it's, the crime focused, catch criminals and out there. And that is a very, very strong cultural characteristic of policing, I think, across the world. And it comes as much from public perception as well. You only need to take a look at Twitter. Anytime we did anything to do with naloxone, you would see these big list of go and just catch criminals and do your job and leave the hell stuff to everybody else. The difference with this was the challenges became very, very organised from the most traditional elements of policing in Scotland. And that, as Inga had said, was the Scottish Police Federation in particular. And they had said, that first of all, it's not the police's job, it's mission creep, it's going to create demand. We don't have good arrangements with the ambulance service just now. Police officers are putting themselves at risk, the normal. But then they got a bit insidious and they started saying things like, police officers would not be insured. So there's an element of scaremongering that was going on. Mm-hmm. Because the Federation's position was, we represent the rank and file, they don't want this. They absolutely don't want this, and you shouldn't be doing it because it's not fair and forcing this onto people. Our view was different. My view of the workforce was different to the Federation, who were a bit stuck in the past, I think, in that perception. And so it became a wee bit of a referendum on their relevance, really, when police officers were starting to be trained and then actually accept voluntarily to carry naloxone as part of the test of change. So I think all the arguments that surfaced were pretty specious, and they had behind two things. One, we don't want to be seen as being irrelevant. And two, and that horrible traditional attitude that nobody would admit to, that these people are criminals. And it's not policing's job to actually invest in helping criminals. That's the old traditional attitude that I think would not be unsaid, which is would not be said and spoken aloud, which is telling in itself. But was the kind of insidious undercurrent to all of this opposition.
That's interesting. And Kirsten, you spoke about compassion. I think, Inga, you touched on that as well. Was there a moment, do you think, where you could see glimmers of capturing hearts and minds and recognising that these are people that don't need to be categorised in a specific way, but rather deserve to be helped? Can you pinpoint any levers, I suppose?
I don't mind jumping in on that. As part of the training for the police naloxone element of it. Honestly, it was some of the most challenging training in my career, just because of some of the attitudinal stuff that was present and some of the division that had been created ahead of the training session. So I find that extremely challenging. So, I think a large portion, probably the majority of people who were on that training, got it, and didn't need the full persuasion around it, but because there had been so much negativity stirred up around it, that was where we got kind of stuck. I mean, don't get me wrong, there were some incredibly stigmatizing things said in the training that we were able to challenge. I do think there was some change, but I think the turnaround point, probably, if we're being realistic, was when we trained people in Glasgow, and then about an hour after the training, the cops that were trained actually used the naloxone on someone to save their life, potentially. So I think that was a real turnaround moment for me, that we were able to use that as an example and get people's experiences of it. And, the sky didn't fall in when they administered it, everything was okay. And somebody's life had potentially been saved. So I think that was a key moment for me.
Yeah, absolutely. Inga, do you want to speak to that as well?
I mean, I think, both Gary and Kirsten have spoke about the training there, and there were maybe some elements there of the lack of trust. Gary was, there were senior staff at the training very regularly in that, which was there as an area to support people to say, look, I'm really supportive of this from a very senior leadership perspective. However, that was interpreted in our findings that maybe a bit of suspicion. Why on earth is there senior leadership there? Because, did I usually come to training? So there's lessons learned there, I think, as well, around that. But yeah, I'll leave it there, because the opposition was strong, very strong.
Yeah.
But it did dissipate very quickly. What we were hearing in our interviews was, very, very much that people wanted to use it. And also the fact that it was voluntary, there was doubt. Well, Police Scotland usually tell us to do something, use this kit. They were saying, well, if it's voluntary, there must be a bit of risk there then.
Okay.
But I don't know if you want to come into that, Gary.
Just very quickly, I think, and I agree completely with Kirsten, and sometimes I cringed at some of the comments that came, but I was far more encouraged by times where not us, but actual other officers in the room were able to challenge those views themselves. Those were pretty good moments. And I think overall, the Federation, who, as I say, very traditional views of the workforce, just actually misjudged the kind of latent attitudes of the workforce, because I think back to when I was a young cop, quite a long time ago. We didn't appreciate things like how trauma and it creates vulnerability and how it leads to addiction. We didn't understand a lot of and I think the younger generation of people do understand that now, are far more educated, are far more aware of the conditions that can lead to addiction, and far more sympathetic towards it. In general terms, as I said, it wasn't widespread across. We still had some pretty toxic views coming forward. But I think in general, police operational officers tend to be young men and women, most of them just out of college and university. They understand, the issues that lead to addiction to a far greater extent than police officers used to, days going by.
Yeah. Okay. And it sounds from what you're all saying that the police carriage of naloxone was about the naloxone and about the very important work of saving lives. But it was also about a cultural shift where people started to talk and think differently, and allowed some training that maybe hadn't been possible or seen as necessary or even bought into before. And Inga, I want to come to you, and I guess I'm wondering, based on your findings so far, what do your findings tell us about what happens when you give frontline officers a kind of public health tool and ask them to use it? What could that tell others as well?
I think it's a really good question there, Tracey, because what we've heard, and we're really keen to explore this further, is that wider organisations, different organisations, are saying, well, hang on, if police can do this, why aren't we doing it? Why isn't everybody carrying naloxone? In the same way as that we teach people to do CPR, why are we not therefore, using naloxone to help people support anybody who is at risk? And I noticed one of my colleagues from Edinburgh Napier is on the call just now. We're trying to move forward that university staff and students are all trained. It's not,
Mhm.
it shouldn't be different. But I think the really, really positive work that's come out of Police Scotland is saying, actually, anybody can do this. And so I think there's a real positive spin that we're seeing in different communities around picking up naloxone and the public appreciation of that.
Yeah, absolutely. Fantastic. And Kirsten, thinking about the safer drug consumption facility, now we know that that took a lot of time and the efforts of a great many people to get into place where it is now. But it's part of a journey, like naloxone, it's part of a long journey. It doesn't address all of Scotland's issues. Um, I wonder if to give any piece of advice based on the learning that you're aware of that to a context that was maybe thinking about introducing a similar facility, what advice might you give?
Buckle up. Especially in the UK, it's so frustrating because,
Yeah.
I think, it takes me back to when when the Taking Away the Chaos report came out in 2016, we established a short life working group, not us at SDF, but the wider Health and Social Care Partnership in Glasgow that SDF was a part of. And it was a short life working group. We fully expected that by the end of that year that we would have the go-ahead to be able to introduce this facility because of the clear need. So I think that's a big issue at the moment that we have in terms of legal barriers, which are questionable in themselves, what the actual legal barriers are to this. If we truly want to treat this as a public health emergency, this is a public health emergency response to be able to provide this type of service. And, if we're going to keep tying ourselves up in knots about some particular wording from a 50-year-old act, I think that's just incredibly problematic. But I would encourage people to get the evidence base for their areas locally. We've seen work on that in Scotland. So in Edinburgh, for instance, a feasibility study to demonstrate also the need. There's a public consultation out for a similar type of facility in Edinburgh at the moment. I think also what if I could wave a magic wand, I would probably have the legal decision making on this devolved to Scotland, so that we were able to just go ahead and introduce these facilities that are so evidently needed. But I would want to be very clear that we can't have conditional service provision, and I think that's been some of the prohibitors for Glasgow being able to fully develop the programme that they've wanted to. So the Lord Advocate's guidance, whilst very welcome, came with a lot of conditions in terms of the way the service was able to operate. And we also have the ludicrousy that we can't offer an inhalation facility at the moment from that, despite the clear evidence that most people are now smoking crack cocaine. So there are a lot of loopholes still to be jumped through, and I think there's a need for us to be much more pragmatic.
Yeah, absolutely. That's interesting. We have a couple of questions from people in the chat. Someone in the chat asked earlier, obviously naloxone doesn't work on all substances. So this person is saying it doesn't work on benzos and is wondering if there's any ongoing research in flumenzil going along with naloxone. I can't speak to that because I'm not sure of any studies, but is anyone on the panel aware of any studies at the moment in relation to that? Yep, Kirsten.
Thanks. Yes, there is some work ongoing to look at that. And flumazenil's, there was discussions when naloxone was very first introduced as a take-home medicine in Scotland. There was discussion around flumazenil, but there was a lot of concern around the seizures that could potentially be introduced if administering flumazenil. So it's never been something that's been used in the community, but there is work looking at that at the moment. But I think the message I would want to express when it comes to that is it's very unusual for people to overdose from benzodiazepines alone. So it tends to be that they're in combination with multiple other substances, and it would be primarily opiates that were involved. So whilst naloxone won't work on benzos, it will work on the opiate, and it will remove the opiate from the equation, which can be enough to bring the person round. So even if you don't have a clue what the person's used, which you probably don't, it's essential to administer it because you wouldn't do any harm, even if opiates weren't involved.
Fantastic, thank you. One quick question, probably for you, Gary, is someone asked earlier when you were talking about what year did Police Scotland's drug strategy come in? I should know the answer to that, but I don't off the top of my head. Do you, Gary?
Yeah, drug strategy, I think, was 2020, and because naloxone was 2021. So I think it was 2020, probably just before COVID, 2019 or 2020.
Thank you. That's great. And there was also a question around how does Police Scotland track when officers have used naloxone, and are officers required to report it?
Yes, we set up as part of the pilot. We set up actually a function in the Partnerships and Prevention Directorate, which continues today just to record the use of naloxone.
Fantastic. Thank you. Okay. And the rest, I'm just having to read through the chats. I think there's a recognition in the chat as well on what you've said as well there, Kirsten, around the Misuse of Drugs Act. I feel like that alone is probably another webinar series all of its own. So we won't dig into that too much today, but just to say that, you know, it's a very valid point, and something that many people are still advocating for and trying to work through. So finally, I want to kind of open something up to the floor of our speakers here. We're sitting here in April 2026 in a political moment that feels in some ways less hospitable to harm reduction than it did a few years ago. The war on drugs rhetoric is back in circulation internationally. And I wonder, how do we hold on to the progress that's been made, and what gives us confidence that this progress can continue? Leave us on a hard note, eh?
That's a very good question. That's an excellent question because, you know, when we're thinking about funding streams around who's going to keep on funding naloxone, even though we've got really good, you know, outcomes around that, where is that? What's that going to look like? So I think it's a really important discussion that we don't just stop and be silent and sit in laurels. There is a lot of work to be done. And forums like this are excellent around keeping those conversations going. I think for me, I'm pretty ancient. I've been around this for a long time. It's taken a long time to get here, and I sometimes see that we're going a few steps forward, a few steps back. And I think it's about keeping it on the political agenda and keeping politicizing it. So I'm sure my colleagues have got other conversations.
Yeah, I'd probably just, my point will probably just amplify that. I don't think when you look over history, you know, progress is a straight curve like that. It kind of goes up and down and up and down. And I think for people like us who are activists in the environment, you know, it's about recognising those moments when it is a favourable environment to act and capitalising on that. We had a very progressive chief constable at the time. We had an authorising environment. We had the drugs task force, you know, and those small moments and those small peak moments, you can actually achieve a lot and set the standard and set the policies for the future. So I would say, recognise that we're going to see this. Generally curves up. I'm quite optimistic like that. But when the moments when we are at the peak and the environment's favourable to us, we should be exploiting that as best we can.
Yeah, fantastic.
Thanks, folks. I'll maybe just add that, internationally it is incredibly worrying what we see in terms of the backlash towards harm reduction, particularly in Canada and the States, have shown, what happens when that political decision-making reverses and goes against evidence-based harm reduction services. Because what we do know is that when those models are taken away, or when that emphasis is taken away, harms increase, there's more HIV, there's more deaths, there's more harms. And in Scotland, we've made progress, albeit a lot slower than we would have liked. But we need to continue that momentum. So we can't be taking any backward step. And I think, what is really required is that strong leadership to keep it on the agenda. Not just becoming neutral, because it can be easier. We still have this ridiculous argument in Scotland about harm reduction versus abstinence, when actually what we need is both, and we need proper investment. I think what's worrying a bit in Scotland is the publishing of a new drugs and alcohol strategy, which is for 9 years, which is good, but it's had alcohol bolted on there with no additional resource. So that would immediately indicate that there would potentially be dilution in drug-related activity. So yeah, all these things really need to be kept on the table, and like others have said, the conversation on it needs to be kept live, and we need to keep challenging it.
Can I just jump in very quickly, Tracey? I think one of the things that we keep forgetting, I absolutely agree with Gary, is that we need to capitalise on when planets align with the right people being in the right positions and whatever. There's also something there about maintain resolve when things are difficult. And actually communities such as this are, you always feel, I suppose, supported, and you feel very much to be able to continue that. I think one of the other things we forget when we're so busy politicizing in trying to keep that, there are humans at the middle of this. There are people. It's a very human issue. And we need to just keep remembering that there are people dying every day, and we need to keep it human, keep it, and not push it into the big stratosphere and hope that it comes out good.
Yeah, exactly. I think that's what's so important about the conversation that we've had today, is about that, just centralizing this. This is all, yes, it's about systems, it's about interventions, it's about change, but it's also about change for a really important purpose, and that is humans at the very core. I've really enjoyed being back with you guys today, and having our discussion, and it's been a pleasure to listen, and to be part of this. Just an invitation to the audience who are listening to us today. Do bear in mind that this is part of an ongoing conversation. I think our panel have spoken really well to how important it is that we create spaces for people to come together and work out, what can we do to be instrumental in that change. There is some information in the chat there about the forthcoming LEPH conference, where we'll be talking about this further. There's also the conference that Kirsten mentioned as well. Kirsten, do feel free to enter some information into the chat about that too. And then we've got the pre-conference event for the LEPH conference, which will focus on harm reduction. And if anyone would like to join GLEPHA and GLEPHA's special interest group on harm reduction, we would very much love to have you join us. We're out of time today. The slides will be shared with you after this. If you would like to have the slides, you can let us know. But I think we'll just send them out anyway to those who've been in attendance. Hopefully you find those useful. If you have any questions, want to reach out to me directly, I am Tracey Price-Allan. You'll reach me at, in fact, I'll ask Vi to maybe put my email address, my Upper Foresight one, in the chat there, so that you've got a contact and I can facilitate any further contact with people who've been on the call today too. So thank you so much. It's been a pleasure. And that draws us to a close today.